We have, I'd like to first of all thank Dr. Leah Jacobson, who's currently in Cambodia on a post at the Children's, I forget the name of the hospital, she'll tell me, at the Children's
Surgical Center
in Phnom Penh. And our board member, Dr. Wilner, who heads the Southern California Ear, Nose, and Throat office or company in Long Beach, California. We'll be hearing from Dr. Kari, who is otology, neurology, and skull-based surgery at the University of San Diego, California, and University of California, San Diego. And we'll also be hearing from Dr. Wagner, who's the founder of Global ENT Outreach. And we will be hearing from Dr. Shohel, who is a clinical professor at the University of California, Irvine, in the Department of Otolaryngology, Head and Neck Surgery. And just to say a little bit about Mending Kids, we're a nonprofit that in non-pandemic times provide critical surgical care to children all over the world in a variety of specialties. And we've pivoted to try and facilitate an exchange of knowledge until we can travel again. And we're delighted to be able to partner with the doctors at the Bugando Hospital in Mwanza, Tanzania, who also helped us coordinate this symposium. And once again, I'd just like to welcome everybody for participating. Also, please note that after the doctors speak, you will have an opportunity to ask questions in the chat box that you have on your Zoom. So please post questions and our doctors will answer them. And I'm going to hand over the symposium now to Dr. Jacobson and Dr. Wilner. So welcome.
Thank you, Isabel. First, I just want to thank everybody who's logged on today. We got very impressive registration of over 100 people from all over the world. And, you know, while this has been a very challenging year, I think this sort of symposium highlights one of the silver linings of the COVID pandemic. We're able to connect, you know, in some ways better than ever and really build a community throughout the world. So I'm really grateful and thrilled to be a part of that. And I'm also very grateful and thrilled to introduce some of my mentors and close friends, really brilliant and talented surgeons and instructors in ear, nose, and throat surgery. The first is Dr. Elina Kari. She's one of my mentors from my residency at the University of Southern California in Los Angeles. She's now, as Isabel said, at UCSD. She's dedicated much of her career to the treatment of pediatric hearing loss, cochlear implantations. She also has some global health background, spent some time in Peru and the Amazon after her undergraduate degree. So I'm thrilled to have her speak to us a bit about pediatric hearing loss. And Dr. Kari will have to leave. So if anybody has questions, Dr. Wilner and I will be fielding questions throughout, and we'll have a Q&A after her session for any specific questions about her presentation. And with that, I give you Elina Kari.
Awesome. Thank you so much, Leah. As she mentioned, she was one of my mentees at USC, and we've had an ongoing mentorship and friendship since then, and it's an honor and a privilege to be here today with all of you. This is kind of like a big, let me see if I can get my out to work. There we go. So I'm going to talk about pediatric hearing loss as sort of an overview of all kinds of hearing loss. I know you're going to have different speakers talking about different topics. I know I was going to talk about sensorineural hearing loss, but I will mention I'll give an introduction to what Dr. Shohel is going to be presenting later. You know, the first thing we need to do when we talk about hearing loss is to define which kind of hearing loss we're talking about. And here you see a diagram of the ear. If the problem involves the external auditory canal or the ear canal, the ear tympanic membrane or the middle ear space, this is much more of the mechanical conduction of the sound waves. And if the problem affects this area, we basically call it a conductive hearing loss. If it involves any combination of the inner ear organ, the auditory nerve, or the central auditory pathways within the brain, all of those disorders get lumped into this category of sensorineural hearing loss, which I think in current terms is probably pretty crude because there are many more nuanced ways to define hearing loss, unfortunately, technologically. And with medical advancement, we have not been able to better detect where the problem is in hearing and in a kind of clinically applicable fashion. So all of the issues that affect the inner ear and above are considered sensory neural. Patients that have problems in multiple locations, which happen quite frequently, have what we call a mixed hearing loss. And so the first step is trying to figure out which type of hearing loss you have. The way that we test the hearing is we introduce the sound first to the ear, either through an insert or a headphone, and that tests the integrity of the entire system. Then what we do is we present the sound to the skull with a bone oscillator, usually applied to the scalp in some way. And that bypasses the middle ear and external auditory apparatus so that it delivers the sound directly through the bone to the inner ear. And then we compare those levels. And the first question that we see is the hearing normal or abnormal? Obviously with children, it's a little bit difficult to get them to raise their hands, especially babies, to tell you that you're hearing or not hearing. And so we need to rely on more objective measures to determine whether children are born with hearing loss. In many countries, we've instituted universal newborn hearing screening to detect if there might be a problem. This is usually done with an automated system, preferably auditory brainstem responses. And this is what we would call like an EEG of the auditory pathway. And this does not tell you exactly what the child hears or what their thresholds are, but it tells you at what level do you see a brainstem response. And that should happen within a certain decibel range. And usually I think the refer cutoff is about 35 or 40 decibels. They usually get a secondary ABR in the hospital before they go home. And if both of those are referred, then the family then gets referred to regional testing for more diagnostic testing. Some centers or some hospitals where babies are born, I should say, use otoacoustic emissions, which is a measure of cochlear function. There are some conditions like auditory neuropathy where you can have normal OAEs, but an abnormal ABR and hearing loss, which is why most centers really advocate for ABR. The cost of these machines is usually not that expensive, especially the automated, but I think from technologically challenged countries, this is really one of the reasons why many children fall through the cracks, because there isn't the practice of newborn hearing screening, and you may not know that a child has hearing loss until they present with speech delay several years later. When the child is old enough, which can be several months in, if they are already turning their head and responding to stimulation, behavioral audiometry is usable, where you don't need you don't need an ABR machine, but it does require a sound booth and the ability to introduce sounds at different specific decibel ranges. The other component of hearing that we assess is what is the clarity of the speech, not just whether they can hear at a certain level, but whether there is a problem with clarity of the sound perception. And so this can only be done when children are old enough to be talking and responding. Tympanometry measures simply the compliance of the eardrum. It is not a measure of hearing loss and should never be used as a screen for hearing loss. So some of the advantages, I think we just went through this. The advantage of ABR, it does not require any cooperation. It does require that children be sleeping though. And this is much easier in the newborn population. When they're sleeping, they can pretty much sleep through everything. Diagnostic versus newborn hearing screen. So a newborn hearing screen is just a binary pass, not pass. Diagnostic ABRs are performed to obtain thresholds. That cannot be done automated. That really requires an audiologist. And these can be performed in children with middle ear dysfunction because they can introduce the sound through bone oscillators as well as through the ear canal. Like we discussed, this is tympanometry. It's simply a probe. I would say it's a cheap device, but it's not super expensive. You can have this in most medical offices with very little maintenance. You insert the probe in the ear canal and you measure whether the eardrum is moving appropriately. Again, this only tells you whether there's fluid behind the eardrum or whether there's a hole in the eardrum. It does not tell you the integrity of the hearing at all. And it certainly doesn't give you the status of the inner ear. These are examples of tracings that you would see in the normal setting. This is a type B tympanogram, which indicates that there's either a hole or fluid behind the ear. This is a type C tympanogram where there is just a leftward shift or a negative pressure reflecting Eustachian tube dysfunction. Type AS is when it does move, but it's shallow, which can be seen in evidence of scarring. And type AD is hypercompliant, meaning it's just more of a floppy eardrum. These are behavioral ways of testing children. Visual response audiometry really assesses child's head movements and eyes in response to sound stimulation. This can be done as young as several months old and up to 2.5. And then conditioned play audiometry is when the children performs practice tasks in response to sound. This is an example of a normal audiogram, and this is the right ear, this is the left. There should always be a legend indicating the laterality and whether it was masked or not. Basically, my rule is if it's red and round, it's right, and then the X is the left. Normal meaning you can hear 20 decibels or less across the range of human frequencies that we typically test, and also that the speech clarity should be in the 96 to 100% range. Hearing loss is classified as normal, mild, moderate, severe, and profound. Not every person is going to have a flat graph. There are multiple variations. You can have a ski slope pattern where you start out normal and then end up in the profound range. This is more classic for kind of age-related patterns when you have a ski slope pattern. You can have a cookie bite pattern, which we typically see in more genetic kinds of hearing loss. And then you can also just have profound no responses, which means you can't hear a thing. I wanted to go through a couple cases of hearing loss. This is an example where you have the bone conduction here in the normal range, but the air conduction is way lower. And there's a gap. We call this an air bone gap. When you see a gap between the bone conduction and the air conduction, that means you have a conductive hearing loss. The tympanogram is flat and you have normal ear canal volumes. This is typically what you see with chronic otitis media or fluid or effusions behind the middle ear. This is the most common cause of pediatric hearing loss. The beautiful thing about this kind of hearing loss is that it's fixable. You can drain it, put a tube in. It typically solves the hearing loss. And by the time that the tubes fall out, the problem has resolved itself. These are much more common in children with craniofacial abnormalities. And for example, for children with clefts, when they're undergoing their initial cleft repair is usually when we put the tubes in. It's really important to treat this problem because this usually occurs between the ages of like 1 year and 3 years, which is really the critical time in language development. And if children are walking around with fluid in their ears, it's the equivalent of having earplugs in. And a lot of these children will have speech delays because of this. Here's another case where you have another conductive hearing loss in the left ear and a flat tymp, but a high canal volume. This is basically, you don't even need to look in the ear. This is a tympanic membrane perforation. And this is an example of a child who has a large perforation here and lots of scarring. You typically don't see an ear like this until a child is older, probably older than 5 and had several years of chronic otitis media. I wanted to highlight this, and Dr. Shohel will be discussing this because this is very common. And cholesteatoma, it's common in the ear world, I should say. It's not common, around the world, but it is a problem that does need to be addressed surgically. Cholesteatoma is a collection of skin in the ear where it does not belong. So there should not be skin any more deeper than the surface of the tympanic membrane. And typically the presentation can be this almost like wax-like debris in the ear canal close to the tympanic membrane, if not adherent to it. And then you may see this sort of pearly mass in the middle ear. Some people may see this only and not see anything behind the drum and the mesotympanum and think this is just ear wax, okay? Wax is only made in the lateral third of the ear canal. If you see something like this adherent onto the tympanic membrane, it's not earwax, and this needs evaluation with an ear surgeon. Cholesteatomas need to be treated surgically, and you'll learn more about that later with Dr. Shohel. Here you have an example of normal left ear, and they can't measure any ear canal volumes on the right. Atresia, which is a very common problem associated with microtia. These children will present with a maximum conductive hearing loss, as you would expect, as they don't have ear canals or normal middle ear structures. The management of this initially, especially if it's bilateral, is that you need to apply some sort of bone conduction aid until that child might be old enough to consider atresioplasty or a surgical BAHA. Unilateral is a little bit controversial, but most of us advocate that children should be aided on that side. And again, you can either consider atresioplasty, although the hearing results, looks like I have a little bit of a typo there. You can consider atresioplasty, but the hearing results tend to be superior with the osteo-integrated implants. Now let's talk about sensorineural hearing loss. About 1 in 1,000 children born will be born with sensorineural hearing loss of varying degrees of severity. It can be anywhere from mild to profound. It can be stable versus progressive. Children can be born with normal hearing and develop sensorineural hearing loss later. Generally, the etiology is about 50% genetic and 50% acquired. The acquired tends to be in the classic, the classic congenital torch infections. CMV is a very common cause now of acquired hearing loss, which is very difficult to detect because it's so prevalent in the community. We don't have a great way of testing people after they've been discharged from the hospital because it's so endemic. Within the genetic causes, 30% are associated with syndromes such as Treacher-Collins or with Cornelia de Lange, or all the crazy syndromes that you might hear about. And then 70% are non-syndromic. So the vast majority are non-syndromic. And 85% are autosomal recessive, meaning that, which correlates to the finding that 95% of children that are born with hearing loss are born to normal hearing families. About 15 to 24 are autosomal dominant, and a small smattering are X-linked or mitochondrial. One of the most common autosomal recessive is the DFNB or connexin 26. Early identification is absolutely critical. And I think if you're going to walk away from one pearl from my talk, it's that spoken language development requires normal access to sound. And the first 5 years of a child's life are really the window when language will happen. If children do not acquire spoken language by 5, 6 years old, it's very, very unlikely that they're going to learn how to talk in any meaningful way. They can learn how to use sign language and communicate in that way, but you can't take somebody who's 7 years old and never heard and never spoken and implant them with a cochlear implant and expect them to talk or get any meaningful understanding of speech. I've heard a couple of things with children and speech delays that people have justified not getting their hearing tested. And some of this is not from parents, it's often from providers after parents actually raise the concern. And they get told, well, he's a toddler, his speech is strange because he's just young. And other families don't feel like there is a hearing loss at all because the child still responds to sound, meaning that they hear something, but it's not enough to give appropriate access to sound for speech. And you can have excellent receptive language, meaning you understand what your parents are saying to you and actually follow commands, but when you try to talk, everything comes out garbled. That's because if you're learning language through garbled ears, you're going to reproduce the garbled sound that you hear. Newborn hearing screen has really revolutionized the way we treat children with hearing loss because it has allowed us to identify them as infants and fit them with hearing aids immediately, which allows them to have more normal access to sound and have less issues with speech development. We also know to have them enrolled within speech therapy before they develop any major speech issues. So at birth, they require 2 failed screens before they get referred for diagnostic testing. For toddlers and young children, typically the first screen would come through a pediatrician's office. Some offices do routine hearing screens, many of them do not. The first step often comes with the entrance into preschool or kindergarten, or if there's a speech delay at 2, 3 years old. I think a speech delay is probably the most common cause that children get referred for hearing testing. There are regional centers that are pediatric audiologists that know how to test children. It does require a certain amount of training and skill. Really, as soon as you have a toddler, it's pretty difficult to do an ABR because they're very, very arousable at that stage. So they'll usually wake up during the test. And then beyond that, you really do need a testing booth and an experienced audiologist to be able to get thresholds and to figure out the degree of hearing loss. There are some automated systems that are, I think, apps through smartphones that have been developed to try and get objective measures of hearing loss with really very little technology. I know that Washington University in St. Louis has worked on an app like this that has been pretty accurate. It has not really come live in a meaningful way yet, and some of the stuff that's available currently in the app world is grossly unreliable. But I do think that with app technology, I think we will get to the point where you will be able to test hearing in a more accurate way without a lot of expensive technology and equipment. Management of pediatric hearing loss. So what do you do when a child has been identified? The current recommendation is that routine lab testing, such as getting urinalysis or renal ultrasounds or an electrocardiogram, is not routinely recommended. There's a bit of controversy about which children, if all, should get these. And a lot of that data really have not borne out routine lab testing. A lot of it should be directed by the patient's medical history and family history. Absolutely, though, all children should have an ophthalmology evaluation and consider a genetics consult. Ophthalmology evaluation is really to make sure that they don't have any other sensory issues, and also to make sure that we identify Usher syndrome, which causes progressive blindness and deafness. I always offer a genetics consult, even though it does not change what we do for that child. But in some conditions, you may identify, especially if it's a multiply involved children without a clear diagnosis of a syndrome, it does behoove you to send them to a genetics expert, because if there are multiple organ systems involved, it is important to identify a potential genetic target, because that can inform the family if there are other health concerns that they should be aware of, or at least be monitoring for. The other thing is that ideally patients should be followed by an experienced pediatric audiologist and speech therapist, not somebody who sells hearing aids to seniors and maybe does one hearing test on a child. There are some nuances on how to program hearing aids and how to evaluate the hearing loss that is really best managed by people who are trained in pediatrics. So this is kind of a crude way for us to describe it, but basically a children's hearing fall into the kind of mild, moderate, or even moderate severe range. They really get referred to for hearing aids. Once you get into the moderate profound range is really when you start talking about cochlear implants, especially if they've had a trial of hearing aids and they are not developing, their language is not developing the way you want it to. There are other forms of assisted listening devices for television. They actually make little headphones that you can adjust your own volume so the entire family doesn't need to hear it that way. For children, there are FM systems in school where the teacher will wear a microphone, for example, and the children have like a little speaker on their desk or wear headphones. There are telephone amplifiers and also dictation specialists for people that are really hearing impaired. Hearing aids come in a number of varieties. They can be the behind the ear, they can be open fit. For most children, because there's such a risk that they fall out, get pulled out, usually you get a pretty occlusive mold, really mostly to anchor the hearing aid in the ear. But for children that have more severe to profound ranges, you really need an occlusive mold with the really high power behind the ear battery and hearing aid. Cochlear implants, which I mentioned briefly before, these are devices that come in two parts. There's an internally implanted component called the internal receiver or the receiver stimulator. Then you have the external transmitter or processor, as we call it. And this is what we call the coil, which has a little magnet that hooks on and then attaches to the magnet within the internal component through this across the scalp. It's completely implanted, so there's no exposure of the device. And then the microphone will be on this part of the cochlear processor, the cochlear implant processor, which will then get transmitted via electrical signals through this internal receiver stimulator. And then these electrical signals are then transmitted to the nerve endings of the cochlear nerve within the cochlea. And this has revolutionized pediatric hearing loss. Before cochlear implants, if you were born deaf or moderately to profound, you might have some sound awareness, but not enough for speech. You would be geared towards sign language and sign community and the big D deaf community. The problem is that children, again, like I said, most of them, 95% of them are born to normal hearing families that don't know how to sign. And essentially it would be like teaching a family Russian that only spoke English if they wanted to speak to their child. And that communication is a big deal in our society. And so this has allowed many children to become mainstreamed, and meaning that they go to regular schools, they talk and hear like normal hearing kids do. There are some nuances that make them not normal, but it allows them to become mainstreamed into society. This is a great undertaking. It is not just a matter of putting the cochlear implant in, giving the child a processor and saying, bye-bye, see ya, never. This is a multidisciplinary process, both before and after the surgery. These children require years of speech therapy prior to going into kindergarten, if not after. And some children are not able to be mainstream. They still need some form of sign. It's very variable what happens in some kids. But we need to emphasize that this really does require ongoing programming and speech therapy in the first 3 to 4 years after implantation. That really requires a center that is able to provide these services. The criteria for CI really keep changing. Currently, it's for prelingual children, it's moderate to profound. They need to be 9 months of age, although we are pushing that now to 5 and 6 months. The earlier, the better. We need to demonstrate that their hearing aids are not sufficient for language development. And we also need to manage family expectations and make sure that their expectations are in line with what we can deliver. We also need to make sure that the child is medically and surgically suitable for cochlear implant. These are pretty minimal considerations. Really, can they tolerate 1 to 3 hours of general anesthesia? Is there a cochlea to be implanted? And will there be a need for future MRI scans? This used to be much more of a problem when none of the implants were MRI compatible. Currently, they are all MRI compatible. However, it does limit the ability to see the brain when you have the implants in. The next question is whether there's a cochlear nerve. That is a little bit, that's kind of my controversial research interest, because we do find that children without a distinct cochlear nerve can still benefit from cochlear implants. It's just much more variable in its outcome, but that's a different topic for a different day. The take-home points, early identification is absolutely crucial. Hearing aids and cochlear implants alone do not lead to language, because it's a multifactorial process that involves the psychological and linguistic capacity of the family. It involves the ability of that family to provide a linguistically appropriate environment. And socioeconomic factors cannot be underestimated. You know, you can take a child with no hearing, give them one cochlear implant, and have them be born to a well-resourced, well-educated, psychologically supportive and linguistically sophisticated family, and that child will have better language development than a normal hearing child whose family is socioeconomically stressed, who is not as well educated or well resourced. And that's a remarkable statistic when you can find that a deaf child with an implant can have better language than a normal hearing child. So I'd like to say cochlear implants are amazing, but I cannot discount the other factors that are important in language development. And then hearing preservation is evolving within cochlear implants. I put my cell phone here at the bottom. I am on WhatsApp, and I encourage anyone and everyone to contact me at any time if they have any questions. I can also have Mending Kids provide you with my email, because I'm happy to be available. I think I have a few more minutes for questions.
So yeah, if anybody has any questions, please put them in the chat room, and then I'll get an indication, or Isabel will flag me and say that you have there's a question. So please feel free to do that. Dr. Kari, can you comment on the timing of the initial assessment? Here in the United States, we have a problem in that, you know, a kid fails their newborn hearing screen, and 4 weeks later they get their second screen, and then 4 weeks after that or 6 weeks after that they finally get in to see an ENT doctor, and their CMV has already destroyed the cochlea.
Yeah.
And one of the things that in our practice we are trying to figure out how to get this done is early or universal CMV testing.
Yes.
Genetically, so that we can catch these kids when an antiviral will actually make a difference. So just in general, not just infection, but in general, the timing of this seems critical. Can you comment on that?
So for CMV, I completely agree. CMV is kind of the big black hole within early identification for us, because we test for so many things before those newborns leave the hospital, but we don't test for the one thing that actually has an intervenable outcome. It's a huge topic of discussion within all of the pediatric and neurotology societies, that we need to develop some universal CMV screen prior to the newborns leaving the hospital. It's turning out to be a little bit hospital and regional specific rather than national or even statewide. I know that here within San Diego at Radius, they are trying to get some form of universal CMV testing on children before they leave the hospital. But I agree. I think that is the one problem where the timing is critical. For other forms of sensorineural hearing loss, the timing is critical just in the sense of not delaying getting their amplification. So, and what we found, as is probably no surprise to anyone on this talk and this meeting, it's hugely dependent on who the payer is in terms of what kinds of insurance they have. So if you have a state funded Medi-Cal, right, which is the state form of safety net health insurance here in the United States, that insurance is not only incredibly variable across state to state in terms of what they cover, but it is just inherent with bureaucracy and delays. So if you have a child that has private pay good insurance, they often will have their follow-up diagnostic ABR within a couple of weeks of discharge, usually just dependent on getting that family in after having a newborn, and usually fitted with hearing aids within a month. If that child has Medi-Cal, they'll probably have like what you described, like another month, another delay. They have to wait for the authorization. And so often it can be 6 months to a year before they even get in for a hearing aid. So, I think CMV is a huge push to get us to get early identification because you can intervene. For the other forms of hearing loss where there isn't really a target with pharmacotherapeutics quite yet, it's mostly just about a delay in getting amplified. But I agree, early identification is a problem. And there are huge regional issues in terms of how newborn hearing screens are not only performed, but also what the follow-up is. So after in Los Angeles, after a lot of families were discharged home and told to follow up, they often had no idea what to do. They were given a list and said, call this number, but it wasn't like it was already set up for them. It was very much like up to the parents as to whether they were going to do anything about it.
Great, thank you. I have another question. I don't see any other on the chat. So if anybody has a question, please enter it. My next question, or my second question, is, cochlear implantation, as you described, it's an undertaking. It takes a village. Yes. And unfortunately, a lot of these kids that we see in Tanzania and throughout Africa are actually from a village, but not the kind of village that can make cochlear implantation a reality. So I understand that it's important to get these kids, all kids, the hearing test done early, get them plugged in so that we can do whatever we can. In one of your slides, you said, where you go from hearing aid to cochlear implant. If cochlear implantation isn't really an option, and yet there are lots of companies that donate hearing aids, and is it still worthwhile to try those kids on hearing aids? Yes. And is it worthwhile from a programmatic point of view for a hospital in Africa to at least try and figure out a way to get hearing aids for these kids?
Absolutely. Hearing loss, listen, I want everyone to learn how to speak if that's what that family wants. But we do have to deal with the realities of what we have in the world, right? And so, just because you have hearing loss or could benefit from a cochlear implant doesn't mean you're completely deaf a lot of the time. So you still have some sound awareness, and at least the hearing aid, if it can't provide normal speech, it provides you with environmental awareness, which is a huge safety concern. Sure. So absolutely, I think that's a wonderful undertaking. I think it's very necessary. You're still limited by batteries, right, which are expensive and not, infinite in their supply for a lot of these children. People in the United States with resources complain about the cost of batteries. The rechargeable ones are an option, but then you need to have electricity. And these are the same issues with cochlear implants. So just because you get them and maybe even get a programming audiologist out there every 3 months, you still need to be able to charge your device. And if you live in a village with no running water and no electricity, you're not going to benefit from that technology.
Great, thank you. I have 2 questions if you have the time. One is, what do cochlear, cochlear implantation post-meningitic deafness, what is the role, and how common is calcification of the cochlea?
Right. So, ossification or calcification after meningitis is very, very common. That said, there are many, many, many successful cochlear implant surgeries after meningitis, even when you see meningitis on the scan. So I would never use the scan to determine not to do the surgery, because you can never determine the true resistance until you get in the operating room. They do have dummy electrodes with one of the companies where you can try a dummy rather than wasting the $40,000 device. You can just use this couple $100 fake electrode and put it in to make sure you get it in. And as long as you get 8 or more electrodes, that is considered a benefit. I think I see the next question. But let me make one more thing about that. There are electrodes that are hardier, meaning they're stiffer and bigger. So they're easier to get in, literally, than some of the kind of gentler, more finer perimodiolar electrodes that are available. And then for auditory neuropathy, because I see the chat now, it does work, absolutely. So if the auditory neuropathy leads to kind of consistent thresholds in the moderate to profound range, children do absolutely very, very well with cochlear implants. Let's see, I see another question. Huge problem of deaf families resisting of CI for their children, even if we could help them hear with a CI. Does this happen in other countries also? And also, how do you deal with this? Or you just stay frustrated, cannot do anything? You know, I guess my question is, are these deaf children coming from deaf families or normal hearing families? Because, you know, deaf families, yes. So the big D deaf community, we call it the big D deaf, where it's an entire community that doesn't hear and uses sign language, and it has its own culture, and they feel that cochlear implants are genocide and that we should not be doing them because it's, anyway. We do have some big D deaf communities, and they rarely come to me for services. So the part of the issue is that they self-select to not come to me. Our feeling here is that as long as you have a language that you will teach your child, that they can communicate with, that's your choice. And, you know, it's not considered child neglect in this country to withhold hearing amplification. It's not considered like not giving them insulin, where you would arrest the family and take the child away from that family. The problem comes when you have that there's no intention to teach them anything. So there are some families that don't get cochlear implants, but they don't sign, and that child has no language whatsoever. That's a problem. We do have some families. I currently have one family where the father is completely ASL dependent, has no hearing whatsoever. A mother has some hearing, some environmental awareness, but she signs to communicate. And then the grandmother is normal hearing, and I think a sister is also hearing impaired. So it's kind of a hybrid family of big D deaf and hearing. And we've had a lot of hybrid families. Actually, I've had two now, where the family ultimately decided to proceed with cochlear implants because they wanted to provide, sorry, my kid is calling me. Let me just, hey Josh, are you okay? I'm giving a talk.
The wonders of Zoom.
What's going on? Sorry. Hit and run. Yep, call the police and then file a report. They're going to need to actually file a police report so you can submit it to insurance. It'll be covered, but let me call you back when this is done. Okay. Is it drivable? Oh, okay. All right. That's not terrible. So yeah, call the police, file a report, take as many photos as you can before you touch the car. And then I'll call you in a little bit. Okay. All right. Talk to you later. Bye. Love you. Bye.
Sorry. I hope everybody's okay.
Yeah, he's fine. Somebody hit and run his car in the middle of the night. So anyway, sorry for the interruption. So yeah, it is, we can't really do anything about the big D deaf community. That's their language, that's their culture. And, you know, honestly, I think it's very hard actually to be a hearing CI child in the big D deaf community. They actually get bullied the same way that our CI kids and hearing aid kids get bullied in our normal hearing schools. And they're really, it's very, very socially difficult for them when they also try to hear. So it's a complicated question. I agree, it's not an easy one to answer.
Well,
all right. Well, I know you have to run, and now you have even more things to deal with. Thank you very much, Dr. Kari. Very informative talk. Really appreciate it. And thank you for answering the questions.
Yes, thank you so much for having me, and I look forward to working with you all in the future.
Great, thanks.
I'm back on. I got cut off there. I can introduce our next speaker, Dr. Wagner. Richard Wagner started the organization Global ENT Outreach. He's trained and developed temporal bone labs all over the world. Currently has a weekly lecture on otology that he provides through his website. There's a WhatsApp that you can join if you're interested and you're not already on his WhatsApp feed. And he'll be talking to us today about, one of the most common problems in pediatric ENT, otitis media. So take it away, Dr. Wagner.
Well, thank you, Lee. I appreciate that. Let me just make a couple settings here. Okay. Whoops. All right. Well, oh, this is really good. Okay. Well, today we're going to talk about otitis media, which is, as Dr. Kari said, one of the most important diseases because the ultimate effect of this disease does delay language development, which, as you can see from this little slide here, also undermines academic achievement. It causes social isolation, and people are at higher risk for injuries and increased poverty when they are affected by otitis media in childhood. Why isn't this moving? Okay, there we go. Before we start getting into this a little more deeply, in 2003, when I lived in New Zealand, I wrote this article with one of the public health nurses. And indeed, in New Zealand and Australia, which are very similar countries, they have a very strong public healthcare system. And we were able to identify in the new school entrance in 3-year-olds that the incidence of otitis media was at 12.4% in 3-year-olds, and the new entrance was 7.7. These were in Pacific Island population. And New Zealand has its own native population, which are called Maori, and it has a large population of Pacific Islanders, which are from any other nation, island nation in the South Pacific. And of real interest here is that the World Health Organization states that if the rate of middle ear disease is greater than 4% in a defined population, it's indicative of a mass health problem and requires urgent attention. Well, in New Zealand alone, which is a very developed country, it's 3 times what the World Health Organization states. This is just a little chart here showing the Maori population, the Pacific Islanders, others, and overall. And this was done in the late 90s. And you can see that the rate in New Zealand is about 10% on average, with greatest incidence in the Pacific Islanders. They have a really strong health service. They have a special vehicle with a microscope so they can go to schools and examine children on site. If the children fail, they'll be able to go to a clinic where there's a public health nurse with a microscope. She'll be able to do oral toilet and otoscopy and make further recommendations as to what the child might need. Another interesting thought, just to share with you before we get into the depths of the lecture, is I spent a lot of time in the Marshall Islands. And the incidence of otitis media is worse in the Marshall Islands than it is in the country of New Zealand. It's probably about 15%. And you can see here the classic tympanic membrane with pus behind it. And most of these children, most, if not all of them, do not get treated at all. Why? Because they don't have access to care, number one. And number two is the infrastructure isn't designed to care for them. So what happens is if they don't get treated, you'll see in a lot of adults ataxia pockets, which can either be very simple and just a retraction, or it could be a cholesteatoma. So these are the early and late sequelae of otitis media that's not treated in places that are very isolated. So what is otitis media? It's basically an inflammation of the middle ear space, which is right here. Next to it is the mastoid air cell, which is like a sponge, the bone around the inner ear that controls balance and hearing, and then another spongy bony structure called the petrous apex. And the most important thing is the middle ear, if it's infected, can spread disease to any one of these 3 locations. And we'll address that in a short while. So what is the otitis media spectrum? Basically, as you can see here, the nice bulging tympanic membrane that has pus behind it. And otitis media, by definition, is an acute infection of the middle ear caused by bacteria in about 70% of the cases. Otitis media with effusion is basically a what is described as an effusion in the middle ear without an infection. There's no pus, and you're not going to culture bacteria. So here's some facts. About $3.5 billion is expended every year just in the United States to treat this disease. It's the most common reason we visit pediatricians. It's the second most common pediatric surgical procedure, and it occurs mostly in children between the ages of 6 and 24 months, although adults can as well get otitis media, but the etiology is quite different in most cases. And in adults, you have to worry about ruling out a tumor. 65% of kids have one episode of otitis media by age 1, and there's a higher incidence as well in white children. And again, this is information from the United States. But from a historical point of view, I think it's interesting that Egyptian mummies have been unearthed and examined, and they've found to have tympanic membrane perforations as well as mastoid destruction. So ear disease is not something of the 20th century. Prehistoric Iranian populations have also had evidence of ear disease. And more recently, in the early 1900s, before the advent of antibiotics, the admissions in New York City at Bellevue Hospital in 1932, 27% of the admissions were for otitis media and its complications. Things have changed drastically since the advent of antibiotics. So we have to look at risk factors, and there's a bunch of risk factors: race, daycare, environment, medical, and we'll talk a little about breastfeeding. But in terms of race, Eskimos, Native Americans, Australian Aborigines, Pacific Islanders, and Maoris, these races have the highest incidence of otitis media. If we look at situations like daycare, children that go to daycare are at greater risk for otitis media, especially when they're under the age of 3. Home care obviously is the best. And when you go to daycare, there's obviously a much more increased risk of exposure to bacteria from other children and increased incidence of upper respiratory infection and the exposure to a greater range of different bacteria and flora. Breastfeeding has been shown to reduce upper respiratory infections as well as GI disease. Most likely it's related to immunoglobulins that are transmitted from the mother to the infant in breast milk. So there's an inverse proportion of or incidence of otitis media in children that do receive breastfeeding compared to those that don't. Environmental, crowded living conditions. In the Marshall Islands, on the one island that I spent a lot of time, in 1 square mile, there's 12,000 people. It's the most densely populated area in the Pacific of any other place. The other thing is people who smoke. It could be smoking cigarettes or burning wood for fire and for heat. And also the other thing is poverty, poor hygiene. Medically, Dr. Kari talked about cleft palates, craniofacial disorders, Down syndrome. There's ciliary function of the eustachian tube lining, immune dysfunction, AIDS, steroids, people who are on chemotherapy, immunologic or IgG deficiencies, patients who have nasogastric tubes or intubated, and children with large adenoids and tonsils. So all of these have something to do with the anatomic structure or function of the eustachian tube. And for those that are not familiar, the eustachian tube is nothing more than a tube. It goes from the middle ear space to the nasopharynx. This is a coronal cut. And you can see here in this image here is the opening to the in the nasopharynx, that's the sphenoid sinus. This is the nasopharynx going up into the middle ear space. Adult eustachian tubes are different than children. Probably the most important thing is that in children, it's a shorter tube because the skull hasn't fully developed. And the angle of the eustachian tube from the nasopharynx to the middle ear in children is about 10 degrees, where in adults, when final development of the skull base occurs, it's about a 45 degree angle. So this has something to do with the ability of drainage. The others are just anatomic sightings here, and we don't need to go over them. The eustachian tube is usually closed. It opens during swallowing, yawning, and sneezing. The opening involves the cartilaginous portion in the nasopharynx, and it's controlled by some muscles that attach to the cartilage, such as the tensor veli palatini. And the purpose of the eustachian tube is to keep ventilation of the middle ear. Any kind of blockage of this eustachian tube will cause a closed space in the middle ear. And if you have a closed space in the middle ear, the pressures in the ear will be abnormal in comparison to the environment. And this is indeed what is one of the precipitating factors of ear disease. If there's no bacteria and we close the eustachian tube, we will get the serous, or we will get the otitis media with effusion. If we have bacteria from the nasopharynx going up the eustachian tube, causing an inflammatory reaction, we'll trap bacteria in the middle ear, and this bacteria will cause an infection, which is basically an abscess. For those of you that are interested, this is just this little chart showing the most common bacteria, Strep pneumonia, although Haemophilus and Catarrhalis and group A strep also are cultured frequently from the middle ear. And respiratory syncytial virus is the #1 virus found in cultures of the middle ear in patients who have had otitis media. But rhinovirus, parainfluenza, and influenza also have been cultured. Well, what are the symptoms? For those of you who have an experience in dealing with children, ear pain, fever, tugging at the ears, hearing loss, poor sleeping, and crankiness are some of the symptoms you'll see. Obviously, if you got a 3-year-old who's got an otitis media, he'll be much more able to tell you that something's bothering him rather than a 3-month-old or a 6-month-old who still can't speak. So you have to watch out for the signs and symptoms in their external behavior. So for physical examination, we can use an endoscope or an otoscope. The gold standard is to use a pneumatic otoscope, and this is easily and readily available in many countries. Fiber optic rigid scopes, you might have difficulty obtaining depending upon where you live. So we look at the color, the position, and the mobility of the tympanic membrane. Here we have a completely normal drum. Here we see a drum with pus behind it with acute otitis media. Here we have a serous otitis media. Here we have an atelectatic drum, which would be the sequela from a chronic negative middle ear pressure. And there's a host of things that can happen here, from a conductive hearing loss to the development of a cholesteatoma. And we can also see perforations and meringosclerosis, which is scarring of the tympanic membrane. So what are the diagnostic tests for children or adults who have acute otitis media? It's pretty simple. If the patient can respond and they're old enough, we can do an audiogram. Pretty much the gold standard, aside from the pneumatic otoscopy, would be to do an impedance or a tympanogram. We can also do acoustic reflexes, but we don't need laboratory and we don't need imaging unless a patient has a potential complication. Dr. Kari went through this. There's the tympanogram or impedance is a very simple test by putting like a pencil probe in the ear canal and measuring pressures of and putting pressure in the ear canal, moving the eardrum to test for resistance. And we have A, B, and C, A being normal, B identifying that there's negative pressure, and C, a negative pressure, and B is completely flat, which would indicate that there's a middle ear problem, which is most likely, in this case, an effusion, as long as it correlates with our pneumatic otoscopy. We have a multitude of options for treatment. If you live in the Netherlands, most likely you are going to treat your patients with nothing more than analgesics. Uncomplicated unilateral otitis media with mild fever or pain, ibuprofen or any non-steroidal anti-inflammatory would be the treatment of choice. If you have fever Severe otalgia, if the child is less than 2 years of age and has bilateral otitis media, most likely you're going to treat the patient with an antibiotic, ampicillin, augmentin, ceftin. There's a host of antibiotics. And surgery is another option. Acute otitis media with effusion that's greater than 3 months bilaterally would be an indication for putting a grommet. Acute otitis media, 3 or more episodes in 6 months, or 4 in 12 months would be an indication for considering putting ventilation tubes in. Chronic eustachian tube dysfunction due to a craniofacial abnormality, and suppurative otitis media with complications would be another one. So our surgical options would be to put a tube in, also evaluate the adenoids and tonsils because they can be culprits, and to make sure that there's nothing blocking the eustachian tube in the nasopharynx. Approximately about 80% of acute otitis media resolves on its own without treatment other than pain relief. And that's why, depending upon the country you live in, such as, like I say, the Netherlands, you might not elect to give antibiotics. The American Academy of Family Practice recommends not prescribing antibiotics for otitis media in children 2 to 12 years with non-severe symptoms if observation is a reasonable option. And again, this came from 2013 publication. I think you have to look at every case individually and what's the best for the patient. So what are grommets? They're little tubes, little ventilation tubes or tunnels that we can implant in the tympanic membrane so that we can ventilate the middle ear space and bypass the blockage from the eustachian tube. Once we've ventilated the middle ear space by putting these tubes in that last usually 6 to 18 months, hopefully the process by which the inflammation in the eustachian tube was caused by has been eliminated. In other words, an infection in the middle ear space has been eliminated. There's no more swelling, and the eustachian tube should function normally. This is what happens in most children. If it's indeed indicated and the grommets are placed, the eustachian tube will return to normal function. The tubes will fall out, and hopefully one set, maybe 2, which should be adequate for most children. There are children that need repeated tubes, and there are some children that need what's called a T-tube, which is a special kind of tube that has the potential to stand for an extended period of time, years, if not longer. And this is what the eardrum looks like after you put one of these little pressure equalization or grommets in. This is a little video. It will show those of you who do not have the experience of doing this. This is a child having a myringotomy for otitis media with effusion. This is not bacterial. This is not acute otitis media. It's otitis media with effusion. So they're using a little knife here to make a little nick in the eardrum so that the grommet or the PE tube can easily be placed without any difficulty. Once the incision is made, knife is removed, and the grommet, and there's many types of grommets. There's gold grommets, silicone grommets, antibiotic impregnated grommets. It depends upon what the individual surgeon likes as to what he will implant. So it's a grommet, depending upon one's technique. In this case, the surgeon is laying the grommet on the drum, and then he'll use what's called a Rosen pick to manipulate it so that the edge of the grommet slips into the middle ear and then stays positioned just underneath the drum. There it goes, it slipped in, and that's the gist of it. After that, you can suction the fluid from the opening there, the lumen, and the patient can go home. Very simple procedure, takes less than 5 minutes. There's also, in the past, there was discussion about using xylitol, which is a sweetener. In a metadata analysis published by the University of Toronto, and they studied about 3,100 healthy children at daycare centers. They found that children chewing xylitol were about 25% less likely to develop acute ear infections. Again, this is somewhat controversial and it depends upon what you believe. So even though this is a relatively benign disease, okay, Eustachian tube plugs up, bacteria gets in the middle ear, forms an abscess, it either goes away on its own, the eardrum can either rupture and the pus can drain out, or you put a tube in. If untreated, there are complications. They can be minor complications or major complications. And you can see here, here's the middle ear space, and abscesses can form at any location, either intratemporal or extratemporal. And I've divided these complications into the minor and the major. Hearing loss is a minor complication because it's going to resolve. And I consider to be facial paralysis a minor complication. In studies that have been done, up to 50% of temporal bones have a zone along the facial nerve where there's a dehiscence, which means that the facial nerve is completely exposed in the middle ear. And when you have bacteria and it causes inflammation, an exposed facial nerve will get swollen and you can get a partial facial nerve paralysis. I've seen many cases where this has occurred, and I have not at this point seen anybody with prolonged facial nerve paralysis. I'm sure there have been, but generally speaking, in a child who comes with a facial paralysis, if you treat them adequately by ventilating them with a tube and putting them on antibiotics and steroids, they should have a complete recovery within a month. Perforations as well occur. If the abscess ruptures in the middle ear space and the drum perforates, most likely it's going to heal on its own. And that's kind of I shouldn't have that there, chronic otitis media. We'll leave that for later. Okay. Major complications, patients can develop mastoiditis, lateral sinus thrombosis, extradural and subdural abscess, brain abscesses, petricitis, labyrinthitis, and cholesteatoma. These are major complications. They all require some form of aggressive intervention, be it both medical and surgical, and they're each a topic within themselves to discuss. And here you see, this is a perfect example of a young boy, okay, who presents with left-sided facial paralysis from otitis media. And he will resolve putting a grommet in, draining the pus, eliminating the infection in the middle ear space, and putting him on low-dose steroids for a short period of time with the antibiotics. So in summary, acute otitis media and otitis media with effusion are common. 80% of children will have at least one bout by the age of 3. A pneumatic otoscopy is the gold standard in diagnosing this disease. Tympanometry or impedance is a good diagnostic tool. And treatment in the United States generally is with antibiotics, whereas in other countries, a less aggressive approach, as long as the patient doesn't show a prolonged symptoms or complications, would be more indicated. And the goal is the goal of treatment is to prevent complications from otitis media, which are rare. The goal is to prevent permanent hearing loss, and the real goal of everything, as Dr. Kari said initially, is to prevent speech and language development problems. That is the bottom line. So this little video, we'll watch this in a second.
See you again. Cheese. Anything else? Madam? The trick? Oh.
Thanks. Our staff will do whatever they can
Thank you so much. You're welcome.
to help make your life a little easier.
So the bottom line is make the correct diagnosis and you'll know what the correct treatment is for your patient. Okay. So that's basically my lecture. If anybody has questions, please hold them and we'll discuss them at the end of the next lecture.
Leah, you want to do the questions?
Sure. Richard, why don't we just do the questions now? There's a couple on there regarding otitis media and treatment with antibiotics.
Okay. So
The first is from Dr. Buname. Why are antibiotics only indicated for bilateral otitis media?
Okay, that's not, antibiotics would be considered for acute otitis media, either unilateral or bilateral. If it came across it was only for bilateral, I'm sorry.
And likewise, another question just about need for oral antibiotics. Is there a need for oral antibiotics?
Again, it's a controversial subject. It's, I'm not a pediatric otolaryngologist, and I'll be honest with you, I don't treat acute otitis media in children because I don't see it. But the bottom line is, if the child just has a mild fever, is not irritable, okay, and it's only been going on a day or two, I think relatively speaking, and again, depending upon the country you live in, a non-steroidal anti-inflammatory would be more than sufficient to take care of the child. If the patient's got high fever, it's been going on for 2 or 3 days, and is sick looking, antibiotics would be the more appropriate approach. But I think you have to do it on an individual basis.
Dr. Wagner, if I can ask a question, when tubes are put in terms of follow-up, because these kids especially in Africa, may not be so easy to have them follow up. How often should they be seen? What kind of care in terms of keeping the ears dry or not keeping the ears dry? What do the parents, what do the docs need to tell the parents that once they put in a set of tubes needs to be done?
Okay, first of all, it depends where they live. If they're village people and they're from the Masai Mara and they can't get to, town, but once a year, a 1 year visit is fine. You just want to make sure that the grommet falls out, and most of the time it does fall out. It does happen that we need to take grommets out in the office, but for most children, they fall out on their own. So 6 months or a year follow-up is fine. There's always the question of, do you keep the ear dry or not? There's really, I think again, it's an individual choice. If I put a tube in, I tell them to keep the ear dry. Why? Because there's always a potential. We now have a pathway from the external ear into the middle ear space. We have a ventilation tube. Do you go swimming? Do you bathe? Again, I tell my patients, put a little cotton in with Vaseline to protect it. There's others that say you don't need to do it. So it's kind of a controversial thing. I'd rather be safe than sorry, especially in somebody who is living in a remote area. And if they did get an infection, they wouldn't be able to be treated. So it's better to be safe rather than sorry in those instances.
Great, thank you.
Mm-hmm.
We have one more from Tomas. If we encounter a child with a ruptured TM already, should we consider topical antibacterial drops?
Well, again, if the kid had otitis media, ruptured their drums, the infection is gone, leave it alone, and usually within 30 to 45 days, that drum's going to heal in a kid. Okay. If there's an active infection, okay, and they've got a perforation, you can put them on ciprofloxacin, and you can put them on ciprofloxacin with or without steroids, and it's not gonna hurt the situation. If they've got an infection, you're just gonna promote the healing process quicker.
Thank you, Richard. I think if there's any other questions, we'll do them at the end so that Dr. Shohel has a chance to give his lecture.
So, I'd like to introduce Dr. Jack Shohel. He's president of Shohel Ear Associates. He's also a clinical professor at the University of California, Irvine, in the Department of Otolaryngology, Head and Neck Surgery. He also has traveled numerous times with his brother, who is also an otologist, to Mongolia. And he's going to teach us the 7 steps that will guarantee absolute success in chronic ear and cholesteatoma management. Jack, take it away.
Thank you, Eyal. And I'm not sure I can follow through on that guarantee, but I'm gonna at least give you a few different tips on things that you can do to better evaluate and manage your chronic ear disease. First, let me thank you, Eyal, and the whole Mending Kids team for inviting me to present today. And this is kind of a continuation of Dr. Wagner's presentation. This is kind of where tubes didn't work or where a kid did not get tubes. This is what happens. So my first step in managing chronic ear disease is you have to be prepared. And that means, you have to take a good history. You have to talk to the patient about signs of impending intracranial complications, things like headache, which is the #1 symptom for someone that has an impending intracranial complication, such as meningitis, abscess, epidural abscess, intradural abscess. This is something that if you see someone who has chronic ear disease, chronically draining ear, headache is a big tip-off that there may be something more going on here. Typically, chronic ear disease, cholesteatoma, is painless. And so if you have someone that has some deep-seated otalgia, deep-seated ear pain, that is a potential tip-off that there may be something else going on, some other type of complication. Normally, people with chronic ear disease do not have fever. So if this patient has fever, you need to be concerned that that there may be some type of more advanced infectious disease, a sigmoid sinus thrombosis, or meningitis. If you have a patient who's presenting with chronic ear disease and they tell you that the drainage from their ear is foul smelling, you need to be concerned that there might be some bone destruction going on and be looking specifically for cholesteatoma. On physical examination, one thing you really want to pay attention to is, here I've got on the side, I'm not sure if you can see my cursor, but this is a tympanic membrane. One of the things I do, I use a microscope in my office when I do my physical examinations, and I understand a lot of people use endoscopes in their clinics. Look for that short process of the malleus, and in particular, look just above it, right here in the pars flaccida area, always to determine whether there might be more disease going on up there. This is where the cholesteatomas live, and it's very important to make a concerted effort to look at that spot. In people who've been draining for a while, who've been treated with multiple antibiotics, I will oftentimes do a culture to see if there's anything I can pre-treat before we do surgery. And then finally, I will do a CT scan also in patients where I think things are a little unusual. Maybe they've had surgery before by another surgeon and I want to look at the anatomy, or if I'm just concerned that there may be more extension than I was expecting. Recently, I've been using CT scans a lot when I'm doing an endoscopic surgery. It helps me determine if I'm going to do a more advanced mastoidectomy. A lot of times I will approach cholesteatoma now through the ear canal through an endoral approach using endoscopes and avoid a more extensive mastoidectomy through a postauricular incision. But by getting a CT scan, I can see how much disease there is preoperatively when we're talking about cholesteatoma and determine whether or not I can do it endoscopically versus having an endorally versus having to make an incision postauricularly. It's very important to get an audiogram preoperatively. I typically require that it's done within 3 months of the surgery. I like our audiologist to do it, but it's very important for the patient's education, for your edification, and here in the United States, especially for medical legal reasons as well. And then finally, you've got to make sure you get proper informed consent. Make sure the patient understands why we're doing this surgery. What are the goals of this surgery? The goal is primarily we want to remove the disease. That is the #1 goal. A lot of people will come in thinking that, I just want to make my hearing better, but they have to understand our number one goal as surgeons, as the treating physician, is we want to get rid of their disease. Our number two goal is we want to reconstruct their ear such that we make recurrence of their disease a lot less likely. And then finally, we hope to improve their hearing. But those first two things come before the hearing. We want to get rid of their disease. And then we talk to them about possibly needing a staged approach. If this is a cholesteatoma, a lot of times it's not realistic to believe we're going to get it all out in one sitting. And so I will usually prepare my patients that this may require more than one operation, and we may plan to come back 6 to 9 months after the original surgery. So the next tip, exposure is king. So you really should make sure you're choosing a procedure to try to maximize the amount of exposure that you're going to need during the surgery. So that'll really depend on how much disease you expect. So that means looking at a transcanal versus a post-auricular tympanoplasty. Post-auricular is going to give you a lot more exposure than a transcanal procedure is going to be, and allow you to reach things that you may not be able to get as easily transcanal. Endoscopes can be very helpful, and if you're going to go transcanal, an endoscope can help you stay transcanal and help you perform a more effective surgery if you're going to go transcanal. And then looking at canal wall up versus canal wall down tympanomastoidectomies. Certainly canal wall down is going to give you a lot more exposure at the expense of some hearing. And also these patients that have a canal wall down tympanomastoidectomy and a mastoid cavity are going to require indefinite debridement and toilet to clean out their mastoid cavity. So the relative indications to do a canal wall down tympanomastoidectomy include disease in the only hearing ear or a dead ear when they have a dead ear on the other side. Disease in a medically infirmed patient, so someone who may not be able to come back to the operating room another time because they have so many other chronic illnesses. If they have an intratemporal or intracranial complication, that would be another reason why you'd want to consider doing a canal wall down procedure. And neoplasms, tumors, are better exposed through a canal wall down procedure. The absolute indications would be if you've got unresectable disease, if you've got so much cholesteatoma that you're going to be leaving some behind for sure, you should take that canal wall down. It'll help you later on with surveillance, and it helps to neutralize the cholesteatoma that you leave behind. If this is a patient that you're never going to get another chance of seeing, they're going to disappear to a village somewhere else, this would be a good reason. It's a more definitive procedure to do a canal wall down tympanomastoidectomy. And then finally, if you have an unreconstructible posterior ear canal defect, so if you're thinning out that bone in the posterior ear canal, and you create a defect, or maybe their disease has created a defect in the posterior ear canal, that would be another reason to just take it down and make a mastoid cavity. So some of the common causes for surgical failure in mastoid surgery include recidivistic cholesteatoma, and that's recurrent or cholesteatoma that has been left over from previous operations. The most common places for cholesteatoma to be left behind is in the middle ear and within the sinus tympani, in the epitympanum, and in the mastoid. It also, one of the common causes for failure is when you have not completely removed all the diseased air cells. So someone with a chronic suppurative otitis media, you could leave granulation tissue uncovered when you don't open up the air cells. And typically the tegmental air cells, the sinodural air cells, the mastoid tip air cells, and the facial recess and the hypotympanic cells are places where granulation tissue can be left behind. Also, when the architecture, what you leave behind as your reconstruction hinders self-cleaning, inspection and toilet, that would lead to a chronically draining ear. So you have to make sure you take that bone all the way down. If you're doing a canal wall down procedure, take that posterior ear canal down bone down all the way to the facial nerve. Remove your mastoid tip. That's another thing that I like to do on all my canal wall down procedures. By taking out the mastoid tip, you allow the soft tissue to collapse down into the mastoid, and you make the mastoid effectively smaller, and therefore less debridement will be needed. Furthermore, you bring some more blood supply to that area through the soft tissues that collapse into the mastoid. Try to unroof the epitympanum all the way flush with the anterior ear canal as well to help open things up, make it more easy to inspect the ear when they come back for follow-up. So this is just a diagram. These are places where you're likely to leave disease behind. A lot of people will shy away from removing the air cells over the tegmen, but that's very important. And what happens a lot with the tegmen is that it'll bow inferiorly and then it'll lift up superiorly as you go more medial. And so some air cells that are more medial in the mastoid up against the tegmen get left behind. And those are a common source for chronically draining ears. The sinodural angle is another important place to remove air cells. People are oftentimes concerned about approaching the tegmen and the sigmoid sinus, but that's a potential place where granulation tissue gets left behind. The mastoid tip is oftentimes close to the facial nerve, so some surgeons will shy away from this area as well, but it's really important to get those areas cleaned out. Next, the facial nerve is your friend, okay? You should be very familiar with the facial nerve anatomy if you're going to do mastoid surgery, and look for it early on. If you find the facial nerve early on, you can protect it and therefore perform your surgery a lot more comfortably and safely. So whatever you can do, whether it's in the middle ear or if you're going to go through the mastoid, find that facial nerve early in your procedure, and that will help you protect it throughout the operation. I like to use facial nerve monitoring when I have it available to me here in the United States. Sometimes when I'm traveling abroad, it's not as readily available, but it is a great safeguard. It's not completely fail-safe, but it is a great safeguard. The most common sites for iatrogenic injury to the facial nerve. So the place you're most likely to injure the facial nerve is within this within this tympanic segment of the facial nerve. So as you're dissecting cholesteatoma in this area, which oftentimes is in this area, and cholesteatoma is very likely to be within this area, you're going to be encountering the facial nerve here medially in the middle ear, and it's dehiscent in 25 to 55% of cases. Use your landmarks, including the cochlear form process, which is just medial to the malleus. The facial nerve should always be posterior to that cochlear form process. And use your oval window. Look for your stapes and look at the oval window. It's going to be superior to the oval window or the stapes, but occasionally, and rarely, admittedly, it can be dehiscent and fall down on top of the stapes on the oval window. Other landmarks within the mastoid include your horizontal semicircular canal. Look for the horizontal semicircular canal early on, and that'll help guide you with your facial nerve. The digastric ridge within the mastoid tip area, I will like to thin it sometimes, and it's going to be medial to that digastric ridge. And as you're thinning out the posterior ear canal, sometimes you'll come across that linear chorda tympani, and that helps guide you towards the facial nerve in the vertical segment. I came across this article many years ago, but it really left an impression on me because I do a lot of procedures through the ear canal, and I'm pretty liberal with doing canalplasties to open up the ear canal and give myself better exposure. And this anatomic study showed that the facial nerve comes lateral to the inferior portion of the tympanic membrane annulus 70% of the time. So as you're thinning out that bone, just be cognizant of any soft tissue that you see here inferiorly, and realize that may represent a dehiscent facial nerve. Number 4, address the mastoid. The mastoid is somewhat of a reservoir that allows pressure changes, environmental pressure changes, to be better equilibrated throughout the middle ear system. So it's important to make sure that in a patient with eustachian tube dysfunction that you've got good communication, that you're ventilating those spaces. I think it's very important to use cartilage liberally. I use a lot of cartilage. I like to get it from the tragus. In most cases, I'll make an incision in the medial tragus and the posterior aspect of the tragus, and I'll take both the tragal cartilage and the perichondrium that's attached to it, and I'll use that to reconstruct the tympanic membrane, to place over the a prosthesis that I might place, to help keep the prosthesis from extruding. I will oftentimes replace the entire tympanic membrane with cartilage in people that have chronic eustachian tube dysfunction. So get ready to intubate afterwards. And what do I mean by that? I don't mean, a tube down their throat for surgery. I mean a tube, a grommet, as Dr. Wagner was discussing earlier. We are addressing essentially the symptoms of eustachian tube dysfunction. Cholesteatoma, chronic middle ear disease, those are symptoms of chronic eustachian tube dysfunction. And we are not really treating that when we do one of these mastoidectomies. So you've got to do, you've got to make sure that you are treating the underlying problem, the eustachian tube dysfunction, by placing a pressure equalization tube. And as Dr. Wagner did a great job showing, there's so many different types, sizes, shapes, and some will last a lot longer than others. Follow-up is as important as the surgery. So routine, I will typically see my patients about 3 weeks after surgery, because the first 2 weeks, you really have to avoid suctioning within the ear canal. If you suction within 12 days of surgery, there's a possibility you could suck up any graft that you placed at the time of the surgery. So rarely will I ever see patients before 2 weeks of surgery after one of these procedures. I will usually see them back with a microscope, and it's so important to see them. You've got to see them back postoperatively, because a lot of times you can avoid synechia that may form in the ear canal. If you take them down quickly, you won't have any issues. But if you let those scar bands mature, it's going to be a lot more difficult to address later on. I will sometimes use ear wicks and ototopicals if the patient has persistent signs of infection after the surgery. Long term, when you've got a more healed up mastoid cavity, one of the things that I found to be very effective in treating my patients with a chronically draining mastoid cavity is a combination of rubbing alcohol and boric acid. Those are 2 readily available ingredients. They're very inexpensive, and they're very effective in treating people with chronically draining mastoid cavity. You have to be very careful, though, that there's no hole in the eardrum if you're going to use that. Any alcohol that gets onto a mucosal surface will be very, very painful. And then I will do a postoperative audiogram at about 6 to 8 weeks after surgery. Oftentimes I will do my second stage if I need to do one about 6 to 9 months after the first stage. And finally, remember, chronic ear disease is chronic. The reason it's chronic ear disease is because it's chronic. As I pointed out before, we're addressing the symptom. We're not addressing the underlying cause. And the underlying cause is eustachian tube dysfunction. That's something that's probably likely to persist long term. And you will have to keep an eye on their ears to make sure that they don't get recurrence of any cholesteatoma, make sure that their eardrum is not collapsing, and use pressure equalization tubes liberally after surgery. And that's all I have. Thank you very much for attending.
Well, thank you very much, Jack. We have some time for some questions because we can. So if people have questions, please submit them to the chat. I have a couple questions for you. One is, how do you talked about the importance of follow-up, and in patients and in areas where follow-up is not so guaranteed, how would you suggest modifying the how you do things?
So that is where using a more definitive procedure is helpful. So if you have a patient that you don't think you're going to be able to see for a long time, and that they've got some chronic ear disease, maybe chronic suppurative otitis media where they're chronically draining, that's where I would use a canal wall down procedure, because although it would be great to see them post-operatively to make sure that mastoid cavity is healing in well, it is not absolutely necessary. So if they disappeared and you never saw them again, at least you know that you've given them a more definitive procedure that is going to make it less likely for them to have a significant problem down the road.
Got it. And that's even though the mastoid, once you do a canal wall down, you need to be a little bit more careful. They are with you for life. You're now married to them. Yeah.
But it is a more definitive operation. And, if they do get lost to follow-up, they will come back in if they're starting to have some drainage in their ear.
Got it. I have a couple of questions in the chat booth. One is the age. Does age influence your decision to do a tympanoplasty in a child? And then the second one is, since the eustachian tube is the problem, what is your opinion on balloon dilation of the eustachian tube?
Okay, so those are two separate questions.
Yes, they are.
The one is the age. Yes, I do take age into account. I am a little more conservative with younger children in repairing tympanic membranes. I try to make sure that they've gotten over their chronic eustachian tube dysfunction before I will repair a tympanic membrane. But there are some cases, especially here in Southern California, where water is a big part of the lifestyle, and it's very difficult to keep a kid out of water here. And the parents are very complicit in them getting into the water, in fact. So there are cases where I will repair a child, but I usually try to have a good sense that their eustachian tube dysfunction has improved before I will repair a tympanic membrane. And the second question was
eustachian tube orifice dilatation.
Yeah, so I do some of that. I'm more of a proponent for tubes, but I find that to be more useful for me in my surfing pop. I have a lot of surfers as patients, and so
they don't
I
want
find
to.
that a lot more helpful for them to avoid having tubes. But I've had a great success with balloon eustachian tube dysfunction, but I've had a few failures too, where they just didn't improve their disease. And currently here in the United States, it's not really covered by insurance, and so people have to pay out of pocket, and you want to make sure that you're doing something that they're going to benefit from.
And can you, there's another question from the chat room about, do you routinely recommend adenotonsillectomy for children with chronic serous otitis media?
I do if I've already put in tubes once before and the tube has come out and they've recurred again with fluid. I will address the adenoids the next time. I do not address the tonsils. I don't think that's a significant. I don't think those are that closely tied into the middle ear that those need to be addressed. But I will do the adenoids if they've failed or if they've recurred with their eustachian tube dysfunction after their tube has extruded.
And I have one last question. Can you comment on the use of the Silverstein tube to just, if it sounds to me like you're just giving up on the middle ear space with that and just going to aerate the mastoid to prevent going from a middle ear problem to a middle ear and mastoid problem.
Eyal, I'm not so familiar with that.
It's basically you drill a hole through the scutum and you put a tube through that, and it ventilates. I just had to take one out, which is the only reason I know about it.
I know exactly what you're talking about now. Yes.
Okay.
I didn't know it was called that. So I don't think that that's the case. I don't think that's why they do that. They drill the scutum. I think they drill the scutum to place the tube because it's more likely to stay long term. That helps secure the tube in place. I don't typically do that. I will do that on an upcoming case, and I think it's the same patient you're talking about. But I will oftentimes, to put a longer lasting tube in someone who's had issues with tubes in the past, I will try to go anterior to the tympanic annulus. So between the fibrous annulus and the bony annulus, I will lift that fibrous annulus off of the anterior tympanic membrane and slip a tube in between the bony and the fibrous annulus of the tympanic membrane. And by doing that, I've had a lot of great success with tubes staying long term. And I'll typically do it fairly close to the eustachian tube orifice.
Okay, thank you. All right, well, I would like to thank everybody for joining us today. I hope it was helpful. It was certainly helpful for us. Very important that we get feedback from as many people as possible. These symposia are for the people who are attending, and we want to make sure that your questions and your thoughts are addressed, whether it's a particular question or particular topic that you would like addressed in future symposia, which we hope to do in, I think, January and February as well, if memory serves me correctly, on different pediatric ENT topics. But if there's a way that we need to gear things a little bit differently for your particular hospital or practice, please let us know. We'll try to include everything that we can. So I'd like to thank everybody. I'll turn it over to Leah.
I think you said all the things, Eyal. Thank you to everybody. And yeah, please do give us feedback. We can cover, or try to cover any topic in pediatric ear, nose, and throat. So let us know. And thank you so much for joining tonight.
Isabel, do you want to give us a final sign off and tell people how they can best reach us?
I just typed it in the chat. I just want to thank everybody for taking part, for giving your time to our doctors today who presented, and just on behalf of even my colleagues like Christina Farut, who coordinated this whole symposium with Dr. Jacobson and Dr. Wilner, and thank you, Dr. Warner, Dr. Shohel, and Dr. Kari. Please do let us know how we can improve these and what topics you want, as Dr. Wilner mentioned, and we will be back with another symposium probably in the next 2 months. And on behalf of Mending Kids, thank you so much for mending kids all over the world.
Thank you. Bye.
Bye, everybody.
Bye, everybody. Thank you.